Hello, good afternoon or good morning, depends where you are. You are very welcome to our webinar number 27 on a very important subject, which is the Droopy tip or the Droopy nose, because this is actually one of the common presentation in your practice. And I'm sure that if you are a rhinoplasty the practicing surgeon, you met at least with 2 or 3 patients a week with Droopy tip who request correction of such deformity. The correction of the Droopy tip actually forms a challenge to the surgeon because it depends on the technique. Many patients, sometimes they come later after a few months, they say, well, my nose after surgery was very nice, very well, nicely projected, nicely rotated, and then suddenly start to drop down 2 to 3 months or 4 months or even 6 months after surgery. And they request a revision. And what's the reason for this? The reason for this are actually that no full key maneuvers has been performed on the primary surgery in order to avoid the recurrence of the Droopy tip. Because sometimes some surgeons do not understand the etiology of the Droopy tip. Why the patient, next slide. I can't move. Next slide. Why the patient has got a Droopy tip? Why the patient has got Droopy tip? There are some etiological factors. What's the cause of the Droopy tip? The factors that contribute to the Droopy tip has to be corrected and treated one by one during the surgery in order to reach the optimum and the best and the long-lasting result. So the main etiological factor of the Droopy tip is the short extended caudal septum, the long lateral crus, which is pushing the tip down, and also the short columella and the hyperactive depressor septi muscles or hyperactive oral muscle which pulls the tip down. Therefore, in order to obtain a sustained, stable tip projection and rotation, you need to treat those factors one by one in order to achieve your results. Can we have next slide? Okay. Can you go for full screen? Okay, these are the key maneuvers in the correction of the Droopy tip regardless of the approach. We need to learn that rhinoplasty is a key maneuver or a maneuver, is not an approach. So regardless how you want to go by, close approach or open approach, those are the maneuvers you have to do in open or close approach or delivery approach or oblique dome division. These are the maneuvers you have to do in order to obtain the best results in that correction of the Droopy tip. Tiplasty, achieving adequate tip projection and tip elevation and tip rotation by doing the new dome creation, new single dome, or new double dome creation, by suture fixation of the dome, by considering the extended columellar strut, which bridge between the medial cura and the caudal septum. This is a very vital step of the procedure. The bridging extended columellar strut between the medial cura and the caudal septum, which in other ways is bridging between the alar cartilage and the bridging between the nasal septum in order to have a sustained tip projection. The tip will not going to slide down or drop down in the future. The lateral crus overlay technique, very important, because in most patients they have a long lateral crus, therefore you need to shorten the lateral crus. And how we shorten the lateral crus without over trimming of the lateral crus is by doing the lateral cura overlay technique in order to get the lateral crus to overlap each other. when we divide the lateral cusp, the cartilage in the midline, that will get the two ends, two medial portion and lateral portion of the lateral cusp to override each other, and in this case, we shorten the lateral cusp and also create like a joint to allow for rotation of the lateral cusp. The division of the depressor septi muscle is very important to reduce the tension on the tip in order not to, because everyone, open and close his mouth thousands of times every day. So by each time this depressor tensile muscle try to pull the tip down, and therefore the tip will drop down, and by continuous tension it will drop down later after a few months after surgery. Therefore, very important to divide the depressor septi muscle. So that's why I said at the beginning we need to treat all the etiological factors that causing the droopy tip. Again, the trimming, the very partial limit trimming of the elongated caudal dorsum, very important to allow space. You need to trim small portion of the caudal septum there, small, about maybe 1 millimeter only, to allow give space for the tip to rotate. That's very important. Again, the long tip graft is very important again, because long tip graft will augment the nasolabial angle and achieve adequate rotation of the tip. Those are the key maneuvers which should be considered in the correction of the droopy tip, and in order to treat the etiological factors that causing the droopy tip. So therefore, it's very important to understand the pathology and the etiology of the droopy tip in order to treat one by one. Okay, so what are the maneuvers in order then? We spoke about the key maneuver, but maneuvers in order in doing rhinoplasty, a close or open approach. You can consider close or open approach, your choice. It's not important how you go in. What's important is what you do when you are in. So you can do either an open approach or do a closed approach, either delivery, or oblique dome division, OBD. It's up to you what to decide. Then once you have done, you choose your approach, closed or open, you need to obtain a septal graft. In primary surgery, usually you obtain septal graft. In secondary surgery revision, when there is no septal graft, you may go for the ear and obtain a condylar graft. And then the third step is to partially trim, very limited trimming of the caudal septum, very limited trimming of the caudal septum, the trimming of the caudal septum, very limited trimming of the caudal septum, about only 1 millimeter, in order to allow space for the tip to rotate, to retract back. That's very important. And again, the delivery of the alar cartilage is a new double dome creation. We need to create a new double dome or new single dome, a new double dome creation. We need to create a new double dome creation, and the suture fixation of the dome in order to fix the newly reshaped and newly arranged tip. And then the most importantly, as we said, the columellar strut, the extended columellar strut, very important, as if we have the nasal septum there, and this is the caudal septum here, and the medial cura is there. And then we need then to put to consider our extended columellar strut like this. And this columellar strut is the bridging between the medial cura and the caudal septum, bridging between the medial cura and the caudal septum. So suture to the medial cura and suture to the caudal septum. And by bridging between the medial cura, and the caudal septum, this will cause obtain a sustained tip projection, because actually this extended columellar strut, a bridging between the alar cartilage and the nasal septum. So the extended columellar strut is very vital, important procedure and important maneuver in the correction of the droopy tip. And then considering again a long tip graft, because the long tip graft, the lower end will augment the nasolabial angle and achieve more rotation, and the upper end will give you more tip projection and more tip rotation as well. So the tip graft also very of vital importance. And then we explained about the lateral core overlay technique. We said in most patients they have a long lateral cross, So we need to do the lateral core overlay technique by dividing the lateral cross in the midline, the cartilage only, with the preservation of the skin, and this will allow the lateral cross to overlap on each other. And once the lateral cross overlap on each other, this will shorten the lateral cross and also allow for rotation. Because this now will work like a joint and allow for rotation of the lateral cross. And at last, the division of the depressor supply muscle, very important, because the depressor supply muscle will cause tension on the tip and keep pulling the tip down during the procedure when you're talking or laughing, and this will cause more tension in the tip. Therefore, the division of this muscle will release the tension from the tip and allow for more sustained and long-term adequate tip projection.
Just in case of wide droopy tip with moderate hum, lady came especially from Iraq to Dubai to have a surgery with me. So I hope you enjoy the procedure. Also, we are doing a double chin correction after the rhinoplasty, which may be called or may not, it depends. Okay, thank you. We start mainly identifying the highest one, the tip on the left, highest one on the right, tip defining point, Can I put the junction between intermediate cross?
Nasal approach, as you see, close approach. And as I said, the first step is to do the hemitransfix incision and obtain the septal graft. And as you see, we are presenting actually the actual time of the procedure. We are not cutting anything. And once you prepare the nose nicely, as you see, and go into the right plane, you will be very easily able to dissect and undermine the left flap. As you see now, we can see the white cartilage. Once you can see the white cartilage inside, that means you are on the right plane. And you see in a few seconds, I elevated the left flap, and now we're looking for the right plane on the right side. And you see, I'm just looking for on the right plane now. And again, in a few seconds, the flap is elevated because I am on the right plane. So you can really actually obtain your septal graft in less than 2 minutes. Once you are well organized, prepare nicely the nose, use your nice local anesthesia, and you see and work on the right planes. So we move about 1 to 1.5 centimeter back, and we using the Bashar knife. We leave one frame 1.5 dorsally and caudally. I will obtain our septal graft, and now I will just trim very limited trimming of the caudal septum. You see, almost 1 or 1.5 millimeter, in order to allow space for rotation. Because as I said, this is one of the etiological factors of the droopy tip is the long elongated caudal septum. So we have to trim this long elongated caudal septum in order to allow rotation for the septum. So once if you miss any of this etiological factor, then you get unsatisfactory result and failure of the procedure. So now just, undermining the slide is the septum, the dorsum. And trying to, you see, I'm working in the right plane, working under the smash. very important to work under the mask. And now we just trim the cephalic portion of the lateral cross, as you see. And again, very important to trim this cephalic portion with preservation of the valve. And this is also will reduce the supraalar fullness, plus it will give you more space for rotation because you need space for rotation. So therefore, you have to trim a very small portion of the cephalic lateral cross in order to reduce the supraalar fullness and have space allowing for rotation. Now, very important point for symmetry that we should define the tip defining point, very important in both sides. Because when you work in symmetrical manner, when you achieve a symmetrical dome, you achieve a symmetrical tip, and then you achieve a symmetrical nostrils. If you do not achieve a symmetrical dome, you will not achieve a symmetrical tip. I will not achieve a symmetrical nostrils. If you get, for example, one lateral cross longer or shorter than the other, you have one nostril horizontal, one nostril more vertical, because one lateral cross is shorter than the other. The shorter lateral cross side will give you more horizontal nostril, and the longer lateral cross will give you more vertical nostril. So therefore, very important to work in a symmetrical manner and identify and mark your tip defining point in order to achieve a symmetrical new double dome creation or symmetrical new dome creation and suture fixation, and this will allow for symmetrical tip and symmetrical nostrils. You see, marking the tip defining point, as you see, and delivering both lateral cross. Very nice and very clean.
I deliver it now.
Just more release of the lateral cross in both sides. You see, don't try to deliver too much. Try to limit your work to the midline as much as possible. The less undermining, less restriction, less exposure, the less wound contraction and less wound scarring following surgery, and less problem of notching or benching or early retraction. I mean, less wound contraction, wound scarring, and less wound fibrosis. Define the tip defining point again. And then let's now with knife excising very small again portion of the cephalic cross. As you see, we are preserving a lot of lateral cross, almost about 1 centimeter of lateral cross being preserved. Very limited trimming, because actually we depend on the correction, on the reshaping, on the rearrangement of the cartilage, not on the over excision and over reduction of the cartilage. So it's a balanced rhinoplasty. It's a balanced maneuver of reduction and augmentation. Now we go with sharp, very sharp scissors under the cartilage and above the vestibular skin, under the cartilage and above the vestibular skin, in order to create a space under the cartilage, in order to allow the cartilage, when we suture now the cartilage together, get the cartilage to cartilage. Because if you don't make this maneuver, when you suture, you get the skin to skin, the vestibular skin together, and it will not heal. So you suture after a few weeks, it will become loose, and you will lose the effects of your suture. You lose the idea of the suture. So the idea of suture is to rearrange the cartilage, to reshape the cartilage, is to get the cartilage to heal to each other. So you need to create a space under the cartilage, above the vestibular skin, before you put your suture fixation. You see now? Yeah. Try be careful not to tease the cartilage, because sometimes if you force more, if you do more force, you can tease the cartilage. Be able to careful. And now we do our suture fixation. Try to stay posterior. I'm staying posterior with the suture in order to obtain a natural looking tip. Staying posteriorly as you see. Staying posteriorly as you see, matrix suture.
Posteriorly,
Yes.
posteriorly to obtain
Dome
natural
matrix suture,
looking.
creating a new dome, and suture fixation. Very important step of the procedure, as you see. And always keep your knot from inside, don't medially, don't make the knot laterally. So this is the right way of doing, exactly the right way of doing it. We're doing the same on the other side. If you have any question, please leave it to the end. I'm happy to answer your question for 10 or 15 minutes. Again, the same suture staying posteriorly, as you see. And now because we undermine under the cartilage will get stuck to cartilage after the suture, and the cartilage to cartilage will heal nicely. You see, staying posteriorly in order to obtain an obtain a natural shaped dome at the end. So this step called new double dome creation and suture fixation. New double dome creation and suture fixation.
Okay. No knife. Knife.
Okay. Now we will score the highest point of that before. Yeah. So we make undermining is there. A slight undermining to deliver the left side to the right side. And now we score the highest point of that top. We need to score it. If we don't score it, you know, you have to remember that the cartilage has memory. And if you don't score, and after under tension, and because of tension of the cartilage may return back to and revert to the original position. Therefore, scoring is important in order to stabilize and fix the cartilage in the new shape. We clean the interdermal space and now make a bucket between the two medial crura. Make a bucket down to just above the nasal spine. Bucket now down. Staying between the medial crura and down to just above nasal spine. And then using the other follicle scissors trying to expose, you need to expose the caudal septum here. You need to see the caudal septum. Because the next step is going to insertion of the extended columellar strut, which is going to bridge between the medial crura and the caudal septum. So you need now to expose the caudal septum. We are just cleaning and removing any connection tissue. Now we go to our cartilage, our graft, and reshape our graft. We need two grafts, one large extended columellar strut that bridge between the medial crura and the caudal septum, and additional long columellar and tip graft. This is graft very important to augment the medial crura and achieve adequate tip projection, as you see now. So nice graft, patient own tissue, as you see. And this is almost the actual time of the procedure. And you see now, inserting this large extended graft. This is one of the vital and most important key maneuver in the procedure, because this is what now we are bridging the alar cartilage to the nasal septum. We are bridging the medial crura to the caudal septum. That is going to obtain a sustained and long-lasting projected tip, this maneuver. So now we are suturing the medial crura to the caudal portion of the extended columellar strut. As you see, the medial crura is sutured to the caudal portion of the columellar strut. A very nice clean surgery, very nice clean surgery. when you do have, this is under very deep sedation. We are using oropharyngeal airways.
And now additional columnar and
Now we make another bucket along the anterior to the medial crura, another bucket down just above the nasal spine, and we insert
definition
our additional columnar and tip graft. So this is long. Why I use long graft? Because I want to augment the nasolabial angle. So by augmenting the nasolabial angle, this is going to give you more rotation of the tip. So some surgeons, for example, they use a shorter graft on the tip or the quote umbrella graft and then put additional graft in the nasolabial angle. So what's the point? You can use only one long graft to give you more stability and more stabilize the tip, and at the same time to augment the nasolabial angle and achieve adequate and more tip projection. So structure again to the medial crura, as you see. Very nice, very clean surgery, very nice organized surgery, as you see. And obtaining a conjoined strong structure of the mediator crura conjoined to that cross with strong foundation of the midline of the medial crura, intermediate crura, the large extended columnar strut, and the additional columnar and tip graft, as you see. Very strong foundation in the midline. You can't get any stronger than this foundation in order to achieve adequate tip projection and adequate tip elevation and adequate tip rotation. And this is really a technique ideal for patients from Mediterranean, mainly Mediterranean patients who have really usually a droopy tip, hump and droopy tip. And this is the ideal technique for the Mediterranean patients from the Gulf, patients from India, from patients from who has really a large hump, droopy tip or boxy tip or trapezoid tip. Now we said one of the etiological factors of the droopy tip is the long lateral cross. Therefore, we have to shorten the lateral cross.
When you have a droopy tip,
And how we shorten the lateral cross is by doing the lateral crura overlay technique, by dividing the lateral cross in the midline, by dividing the cartilage with the preservation of the vestibular skin. And this so we will not trim, we will not over trim the lateral cross, we will preserve the lateral cross. This is a preservation technique, as you see. Excising the cartilage with the full preservation of the vestibular skin, and allowing the two ends of the lateral cross to overlay on each other, and this will shorten the lateral cross and allow for more rotation. Also, by doing this maneuver, it will create like a joint which allows for more upward rotation. So you get two benefits from this maneuver: is by shortening the lateral cross and rotation, more rotation, because creating a joint make it more easy for that lateral cross to rotate upward. See, extremely nice work, clean work, as you see. You can do either one side or you do both sides. It depends how long is the lateral cross. But mainly that you preserve the vestibular skin.
All the sharp edges now.
Remove the sharp edges.
The other side now.
We're going to see on the other side. You see now how nice, how symmetrical the nostrils are coming out, because we work in symmetrical manner. We accurately define the tip defining point. We actually perform or obtain adequate symmetrical double dome creation. So therefore, we are definitely going to obtain a symmetrical nostrils. So again, lateral crura technique on the other side with full preservation of the lateral cross, of the vestibular skin. And this again will allow the two lateral cross to overlay on each other. That's going to shorten the lateral cross and solve one of the etiological factors of the droopy tip, plus it will allow for rotation.
Lovely, lovely. Look at this lovely profile.
Look now at the very nice open nasolabial angle, a nice double break, a nice supratip break. Look at nice symmetry of the nostril. You can't get any better symmetry than this. This one you work in actually in accurate and symmetrical manner. Now you can now at the our extended columellar strut at the cephalic portion of the our extended columellar strut and suture now to the caudal septum. So what we are doing now actually we are suturing the cephalic portion of our extended columellar strut to the caudal septum. So this is the nasal septum, the caudal septum, the medial crura, and this is our graft, and it's sutured now to the caudal septum there, as you see, sutured to the caudal septum. So now, I mean, the extended columellar strut has been first sutured to the medial crura, and now it's sutured to the caudal septum. That means you are actually bridging between the medial crura and the caudal septum, a bridging between the alar cartilage and the nasal septum. So by bridging between the medial crura and the caudal septum, that will form a quite fixed alar cartilage or fixed tip to the septum, and this will not allow for any sliding down of the tip in the future. You could already have a bridge. You have a bridge between the medial crura and the caudal septum. You see, very nice work, very nice clean work, and using all absorbable sutures, because most of the patients actually come from abroad. This patient, for example, she came from Iraq, she came from Baghdad, especially to have her surgery, and now she will go maybe back to Iraq after a few days, so she will not have to worry about moving or the sutures. All sutures are absorbed, as you see. Now, first we suture cartilage to cartilage. Now we are suturing the flaps together. We are showing the almost the actual time of the procedure. We only cut maybe 3 or 4 minutes only of the procedure. Only when there is nonsense and we're doing nothing.
Well, this is septocolumellar, continuous.
We call it septocolumellar sutures. As you see, and we use BDS for this.
You see, very nice profile.
Look, extremely nice profile. The transformation of a Droopy tip, acute nasolabial angle to an open nasolabial angle. To nicely look at this now. Under-projected tip, short columella.
Extremely nice tip projection.
Extremely nice open nasolabial angle. Extremely nice profile.
Section last tip, mark and bend.
You see how symmetrical are the nostrils, because we work in symmetrical manner from the beginning. Marking the tip defining point on the skin, then mark the tip defining point on the cartilage, on the dome, and then the double dome creation and suture fixation in symmetrical manners. And now we are doing the alar wedge resection. This is my technique again. It's called the finger technique. You don't need to take any measurement, because when you take measurement, most people have asymmetrical nostrils. So when you take measurement, you are taking just the asymmetry, moving this asymmetry from asymmetry to asymmetry. So if you have watched me doing this, you know how I do it. And if you, because it was a bit quick, you can go to the YouTube and write my name and put alar wedge resection. You can see more detailed and more comprehensive videos on the alar wedge resection. Again, we use absorbable sutures here, and usually after we leave the curvature there, we do again subcutaneous suture, because again most of our patients come from abroad. I don't like to use bromine. I use subcutaneous sutures because then the patient do not have to worry about removing the sutures. We'll be going now subcuticular all the way through, as you see. Exactly subcuticular now. This is the obvious area.
Sound.
And usually, actually, after 3 weeks, most patients have no scars or no trace of scars there. And really, in many occasions, I had to look at the patient file and read my operative note to see if I have done airline wedge resection or not. Because by looking directly at the patient, sometimes I cannot predict any scar. So it's very beautiful, very nice technique. Also uses absorbable monocrene, which will save you again, save the patient, return him back to the surgery, and having the body removed. So this procedure actually is the full Indonesian approach, obtaining septal graft and full tiplasty, as you have seen, overlay technique and septocolumnar resection and air wedge resection. Was the total time was almost 35 minutes, only 35 minutes. Was the full the total time was actually of this procedure.
Other side now.
And again, we do the other side. Again, be the same way. I think we can bypass it because it will be the same. Can we just go slightly, again.
Okay,
So again, we did subcuticular all the way through, as you see. Very nice.
Creation, suture fixation, abdominal suture, abdominal suture, extended large columnar septal graft, additional columnar and tibial graft, microtocal overlay technique, airline wedge resection, in how many minutes now? Sorry, 35? 35 minutes. So if you are seeing very nice artistic work, look at this profile, extremely also C1. Nice.
Look at this beautiful profile. Look at beautiful profile.
Nice break. We didn't have to remove this.
35 minutes for such a
We
procedure.
have done nice to work. So we perform this.
Droopy tip, under projected tip, as you see. The breast tip,
Almost
wide bulbous tip, as you see, quite wide tip.
Wide tip, as you see, very large wide tip.
Thick skin.
Anyway, what it will be highly descriptive now, what it will be highly descriptive. I hope you have enjoyed this technique and you have seen the key maneuver. It's like enjoys the airline delivery, the new creation, the suture fixation, the interdermal suture, the transdermal suture, the large extended columnar and septal graft to bridge between the medial dura and the caudal septum. The additional columnar and tibial graft, the very important bilateral overlay techniques in order to shorten the lateral cross and achieve no tib rotation. The airline wedge resection, this was in 35 minutes. Social science over anesthesia, the profession, this is a laryngeal mask, it's not an endotracheal tube. So this is Bashar Bizrah from the London Academy of Facial Plastic Surgery and the Rhinoplasty Bizrah Academy.
Okay.
Thank you for watching.
Yeah, okay. So you can see the difference now on table. As you see, extremely nice results. So our aim is to teach you the technique. I'm not here going to show you pre and post of photograph of my patient. We have thousands and thousands of photographs. I'm not here to make a show for you. I'm here to teach you the technique and how we do it. If someone wants to see our result, he can visit our Instagram or our my website. Okay, that's my go back. Sorry. Yes, okay. Yeah, so we missed one who is the video of the want to show you the division of the depressor septal muscle is very important. Yeah, because I think we forgot to record this because we did it because I forgot during the procedure, so I had to do it after. Oh, can we show you now? Because we said one of the etiological factor is the is the hypertrophy of the depressor subtile muscle. So we need to show you that you should really divide the depressor subtile muscle in order to have a sustained and long-term result. Because if you don't divide the depressor subtile muscle, this under the tension, the tip may drop down in the future. So division of the depressor subtile muscle is of vital importance.
Yeah.
You see, I have done it.
For human here.
30
So we divide the foramen and then we expose the nasal spine, as you see, expose the nasal spine. And this is very important step. And then we scratch and elevate the muscle from over the nasal spine. Very important to divide the depressor subtile muscle, because I say this is we treat the etiological factor of the Droopy tip one by one. So what are the etiological factors of the Droopy tip? 1, 2, 3, 4, and we treat one by one. And this is now one of the main etiological factors also is the hypertrophied or the hyperaction of the depressor subtile muscle. And then I suture the muscle up to avoid that the muscle to heal down to the same plane down. So by doing this suture, we keep the muscle healing in upper plane, and this will give me more rotation because the muscle is going to heal back at least 50 or 60%. You cannot stop the muscle of not healing back and retaining some fibers again. So by doing this suture, it will help you to avoid recurrence as much as possible and help and make the muscle to heal in a higher plane. And by the muscle healing in a higher plane, that will obtain and achieve a more rotation of the tip and more sustained and more long-term rotation of the tip. Okay. So that's very clear. Look at this nice symmetry you obtained, and nice tip projection, nice tip elevation. And this is okay. Let us move now. Back. So now again, in Droopy tip, it's not important what approach you use, open approach, closed approach. Sometimes people have an endless and unnecessary discussion about open approach or closed approach. It's all in my opinion, it's very unnecessarily because it's not important how you go in. What important is what you do when you are in. What important is the maneuvers. Rhinoplasty is based on maneuvers. Rhinoplasty is not based on approaches. Nobody says that rhinoplasty is based on approaches. Most of my patients are revision. 80% of my cases revision. If I have, for example, 4 in the list, sometimes all the 4 cases are revision from another surgeon or 3 of them. What we all been done before by open approach? What the surgeon did? He did nothing. They make open approach and they did some interdermal suture and that and they close. So that's why approach is talking about the approach is absolutely rubbish. What you should talk about the maneuvers. What you have done when you are in. That's the most important. What is most important are really the maneuvers and the key maneuvers that you consider when you are in. What you are going to do when you are in. Are you going to do a new double dome creation, suture fixation, extended columnar strat, columnar antigraft, that occur overlay technique, cast approximating sutures, septocolumnar suture, dividing the depressor subtile muscle, that occur overlay technique. Those are the maneuvers which are important. Okay, we'll go back to the lecture. Maneuvers are important to consider when you consider the correction of Droopy tip or consider doing rhinoplasty. So in rhinoplasty, you have to make first of all a good judgment of the patient. When you examine the patient in the clinic, go back, Mr. Zahra. When you examine the patient in the clinic, you have to make a list of the deformities and then track each deformity one by one during the procedure. You need to work in an organized manner. So that's why what you are going to do, what important is the maneuvers that you are going to do to correct those deformity. So very important is to very important. So after very important is to list the problem and correct the problem one by one and understand the etiology of the deformity and then correct all these etiological factor or pathological factor one by one in an organized manner. Next slide, please. Okay. Okay, question and answer. I have one good question. Okay, next, go to HQ, please. Right. Yes, okay. Stay here. So what he said, in lateral cooperative technique, do you undermine the anterior or posterior half? You mean either the medial or lateral? Actually, you better always to undermine the lateral portion and to keep the medial portion more stable. But in some cases, like this case, which we done quite too long, the lateral cross, so we had to undermine limited both sides, medial and lateral. But if you can manage with the lateral only, that's adequate. So preference and priority to the lateral portion first, because we always want to keep the dome at the midline more stabilized and more stable. Another question, in limited quadriceptor treatment, do you separate it from the anterior nasal spine? No, you don't have to, unless there is a severe caudal dislocation. You don't have to, because we actually trim the upper portion, not the lower portion of the quadriceptum. You don't have to trim the lower portion, because usually the elongated quadriceptum in the upper portion of the quadriceptum, not in the lower. So you trim the upper portion, so you don't go down near the nasal septum. How do you correct the dorsal hump? Okay, this is next another webinar, inshallah, because this is a different subject. Our subject today is the Droopy tip. So the dorsal hump will be, just follow me and we'll send you email about the next webinar. We may consider dorsal hump or another, but it will be coming, inshallah. So we go by in an organized and systemic manner. For example, we start our webinars again this year about the crooked nose, about the hump, about the African nose, about the Southeast Asian nose, about the, we said crooked and deviated nose, boxy tip, trapezoid tip, bifid tip. So we'll revision rhinoplasty. We'll go by, in each webinar, we'll cover one subject. Also, we'll be doing webinar on blepharoplasty and on the deep plane face and neck lifting. Any more questions? So no more questions. Thank you very much for watching. I hope you find it useful and interesting, and very important that, again, I emphasize that rhinoplasty is not approaches. Rhinoplasty is maneuver. You should do the right and the correct maneuver. Good judgment, good assessment of the patient pre-operatively, and list the deformity, and then considers and list the maneuvers which you are going to do to correct all those deformities by one, whether you go open or endonasally. It depends on your skills and depends on your preference and what you like and what your patient like. Thank you very much. See you soon. Bashar, Bizrah. Thank you very much.